Okay, so today we're going to be going over a little crash course over musculoskeletal. All right. So first we're going to be starting with chapter 53. So the first thing we're going to cover is osteoporosis. So osteoporosis is the deterioration of bone tissue and density. So it's going to be the most common bone disease. 50% of females will experience osteoporosis after menopause and will have fractures. So a little bit about bone anatomy, what is really going on here. So you have two types of cells, all right? You have osteoclasts, which their role is to break down bone by adhering to the surface and secretes enzymes into the bone cavity. Osteoblasts are going to rebuild new bone by creating new bony matrix in the cavity. So osteoblast starts with a B. They're going to build. Osteoclast are going to crash and burn everything down. All right. So blast, build, clast, crash everything down. When osteoclast activity is greater than the osteoblast, it results in osteopenia, which is going to increase the risk of fractures for patients. So a BMD, a bone mineral density, what this shows, depending on what the level shows, is going to determine the osteoporosis status. So your bone density is going to peak at around 25 to 30 years of age. And then there's 3 risk factors that increase your risk for osteoporosis with aging. So the first one is going to be low calcitonin levels. Second is lower estrogen levels. And the third is increased parathyroid hormone. All right. And spongy bone is going to be lost before the compact bone. And when you have a low bone mineral density, your bones are going to be porous, they're going to be brittle and fragile, again, increasing your risk for fractures. And then with osteoporosis, the areas that are going to have the most bone loss are going to be weight-bearing structures. So that's your lumbar spine, your hip, and then even sometimes certain wrist fractures. Osteoporosis is kind of known as like a silent diagnosis because normally a person will not get diagnosed with osteoporosis until they have a fall. So the gold standard assessment, again, is going to be that bone marrow density. It's going to be best for women who are above age of 65 or postmenopausal. And for males, it's going to be above the age of 70. And a DEXA scan is the diagnostics used for osteoporosis. This is going to show precise measurements of skeletal points to assess the risk of fractures. So when you are treating osteoporosis, the big thing is going to be prevention, right? You can't necessarily cure osteoporosis, but you can prevent and you can help slow progression. So treatment, again, is that prevention screening. Weight loss and muscle strengthening activities are used to, again, help keep the bones and joints strong and stable. And vitamin D and calcium are 2 supplements that you can use for prevention. And with calcium, you're going to want to take 1,200 milligrams daily. And vitamin D is going to be about 800 a day. You can also educate on healthy diets to help prevent osteoporosis. So foods that are high in calcium and vitamin D are going to be milk, fortified cereals, egg yolks, saltwater fish, and liver. And if you want to further educate, you can even tell your patient to have 15 minutes of sunlight a day in order to help with that vitamin D absorption. So complications of osteoporosis include skeletal changes from bone loss and lack of remodeling. Again, if they're a higher fall risk, they have a higher risk of developing fractures. And during your assessment of osteoporosis, things you're going to note on your patient will be a dowager's hump, otherwise known as kyphosis, so kind of like a hunchback of the dorsal spine, a decrease in height. They can have sharp and acute back pain or increased pain with activity, fall phobia, and also a history of fractures. And giving biphosphonates is going to impede osteoclast activity and increase calcium reabsorption in the bones. Now we have osteomyelitis, which is an infection of the bone caused by bacteria. There are two types. You have a hematogenous, which is spread from one area to another throughout the circulation, and you have non-hematogenous, which is the bacteria enters through an open fracture or bone trauma. So the cycle of osteomyelitis first starts with invasion of the bone by a pathogen. So the pathogen enters into the bone. Phase number 2, it's an inflammation and increased vascularity in the region. So you're going to see that edema within the region. 3, a thrombus develops, which causes ischemia. Again, you're going to have that thrombus in the vessel. It's blocking blood flow. The tissue starts to get ischemic. And then 4, the bone becomes necrotic and wound healing is delayed. The hallmark sign of osteomyelitis is going to be bone necrosis and presence of sinus tracts between the bone and the skin. Clinical manifestations of acute osteomyelitis are going to be constant pain, swelling, warmth, chills, fever, and malaise. Chronic manifestations are bone pain, edema, tenderness, warmth, and erythema. Children often do not experience fever and pain and these increased inflammatory markers with osteomyelitis. The diagnostics for chronic osteomyelitis are going to include getting a white blood count to note the infection. The ESR and CRP are used to determine inflammation, and blood cultures. Blood cultures is going to tell you which type of bacteria or pathogen is in the bone. So it's going to be positive with soft tissue edema, bone degeneration, and a positive periosteal elevation, which that means the bone is enlarged due to pus. And the gold standard for osteomyelitis diagnostic is a bone biopsy. Medications for osteomyelitis, it's going to be antibiotic therapy and debridement. So first, when you're waiting for that blood culture to come back, you're going to want to start the patient on a broad spectrum antibiotic. And then the first line antibiotic for osteomyelitis is going to be those beta-lactams, so penicillins and cephalosporins. If the patient their blood culture has come back positive for MRSA, you're going to want to give them IV vancomycin because it is a very strong antibiotic, and MRSA is one of those methicillin-resistant infections. If needed, a staphylococcus alternative, you can use quinolones due to their ability to penetrate the bone very strong. And for chronic osteomyelitis, if nothing's really working, you can go in with those surgical antibiotic beads and insert them directly into wherever the bone infection is. You're also going to want to use opioids for pain. Again, bone pain is one of the most severe pains that you can think. So you always want to believe the patient when they're talking about their level of pain. And you want to encourage a high protein diet, again, for that wound healing. And then debridement is only used for when antibiotics are not having any effect and soft tissue abscesses are now forming. Complications of osteomyelitis include sepsis, amputation, squamous cell carcinoma. So when you are doing your nursing management, you want to assess for increased white blood cell counts, any inflammatory markers, irritability, as well as malaise, difficulty bearing weight, a stiff back, and poor perfusion are all going to be signs of how osteomyelitis prevents. Actions and implications for the nurse: obviously administer antibiotics and pain meds as ordered, and use of thermal therapy can use to help increase that blood flow and range of motion exercises. And you also, again, always want to educate on the proper diet and why. So again, high protein for wound healing. So now we're going to jump into joint replacement. So joint replacement is replacing the articulating surface within a synovial joint. This is typically going to last 10 to 15 years, so it is not really seen too often in younger patients, or anyone really under the age of 70 due to the need for it to be replaced. So osteoarthritis is the number one indicator for needing a joint replacement. Because it's causing the decrease in the proteoglycans, which is causing that decreased cartilage. Usually cartilage is a blue to white color, but with a joint replacement therapy, it's going to turn into a yellow to brown color. Yes. So what's actually happening here is it's a narrowing of the joint space and erosion caused by production of osteosphytes. So this is when you're going to start to see those bone spurs form. And again, you're going to have an increased inflammatory response due to the cytokines being produced, which is going to cause further destruction. So the diagnosis of a joint replacement therapy is based on deformity, tissue destruction, a loss of function or reduction in function of a specific joint. X-rays determine the need for a total joint replacement, and the MRIs will show the structure and the joint pathology. Treatment of a joint replacement is going to initially focus on weight management, NSAID therapy, and joint supplements. But once a total joint replacement is needed, a comprehensive physical exam needs to be conducted. And what that looks like is you're first going to assess range of motion. So you're going to note any contractures. The second thing you're going to note is the patient experiencing any crepitus or pain during flexation or extension. The third thing to note is you're going to examine the ligaments for stability and contractures. The fourth thing is you're going to examine the spine and the hips. 5, you want to note the tone and the strength of neuromuscular function. And then you're going to want to assess the gait, the pulses, and the skin. If the patient is experiencing an active infection, a neurological condition affecting function of lower extremity ischemia, and skeletal immaturity, total joint replacement is contradicted. So these patients cannot have a joint replacement therapy if they have any of those or a significant medical condition, which would include things like a myocardial infarction, heart failure, etc. So surgical management. So there's 2 types of approaches for a total joint replacement. You have a cemented approach and an uncemented approach. So for older adults who unfortunately have less than 20 years left to live, the cemented approach is what is used. What you're doing is you're using cement to attach the prosthesis to the bone for a stable fixation. And these are for, again, patients not likely to need revision surgery. For an uncemented approach, what is happening is a hole is placed in the bone, anatomically correct, which allows for the bone to grow into the prosthetic surface itself. And this is used for younger individuals that may need to have revision surgery in the future. And this is going to increase joint movement. So complications of a total joint replacement, the immediate thing you want to look out for after surgery is think of your hypos. So hypotension, hypovolemia, and excessive bleeding. You also want to note for wound infection, so keep asepsis and prophylactic antibiotic treatment. Critical complications of a joint replacement is going to be dislocation and subluxation. And these are both seen with asynchrony in the leg or an abnormal hip rotation. So nursing implications, you're going to want to have that early ambulation. You want to use anti-embolic stockings for prevention of venostasis or clots. And you want to administer anticoagulants for 4 to 6 weeks post-surgery. And one big thing, again, with that anticoagulant therapy is you need to educate your patient on anticoagulation teachings, I guess. So again, no electric razors, soft toothbrushes, no floss for any high risk activities such as like playing football, riding a motorcycle. And if they're on warfarin, you want to remember to educate them to keep their vitamin K intake consistent. They don't need to increase or decrease. Some home care for them to note is they should be doing 2 sets of 30-minute exercises a day. You want to have a raised toilet seat with rails, so that way they're not at risk for dislocating their hips. Again, you also don't want them to cross their legs due to hip abduction and DVTs, and educate them on the use of assistive devices if needed. So now we're on to chapter 54, which is musculoskeletal trauma. So the first one we're going to talk about is soft tissue injuries, so sprains and strains. So a sprain is an injury to a ligament or surrounding joint that is caused by twisting or wrenching, seen in the knee, wrist, and ankle. And a strain is excessive stressing of a muscle and fascicle sheath involving a tendon. So these are going to be your large muscle groups, so your lower back and your hamstring. Nursing care is going to be using the RICE method. So rest, ice, compression, and elevate. And when it comes to using ice, you can apply the cold therapy for 30 minutes or less, unless this is seen in an area with small capillaries. So like the face or fingers, you only want to do about 10 minutes at a time to allow for the blood vessels to, quote, thaw out. So that way they're not getting constricted too much and causing more damage. So now we're on to fractures. So fracture is going to be a break in continuity of the bone. So we do need to know all the different types of fractures, which I will get into on the next slide. But there are 2 types of fractures. You're going to have a complete, which is across the bone, causing fragments. And then you have an incomplete, which is going to be across the bone cortex, but no displacement of fragments. And then the picture on the bottom is showing you a closed and an open fracture. A closed fracture is contained within the skin, and an opened fracture creates an external wound. So that skin is broken. So here are some of the fractures that we do need to know. So the one on the top left called a green stick, and this is most commonly seen in children due to the flexibility of their bones, and it's incomplete, and one end of the bone is bent and the other end is fractured. So if you can see here, the bone is kind of bending upward, but there is still a fracture within the bone. An oblique fracture, it's like a slant throughout the bone or 45-degree angles. A comminuted fracture, it's going to have several disruptions with many shattered bones. And then right next to that is going to be a spiral fracture, which is going to wrap around the bone cortex. One thing to note with spiral fractures is almost 100% of the time they are caused by some form of abuse due to the excessive twisting and breaking of the bone. The picture of the skull right below the spiral fracture, that is known as a depressed fracture, which usually is seen on the head, and it's forcing the bone to go inward, usually caused by blunt force trauma. And then the one on the furthest right is going to be an impacted fracture. This is where bone segments are wedged into each other at the fracture line. So the worst type of fracture to heal is going to be that comminuted fracture. And this is when you want to think of like Humpty Dumpty, right? He fell off the wall and broke all of his bones. They're very hard to put back together again when you have this type of fracture. Age is also going to determine how long it takes the body to heal. Diagnosis for a fracture is going to conclude a CT or radiography. And again, you always want to make sure you're compiling a history of how the fracture occurred. Treatment for a fracture is going to be antibiotics for that open fracture because they are at greater risk for developing an infection. pain control, and you want to make sure that this patient is ambulating so that their muscles are not starting to atrophy in the affected extremity. For closed fractures, you're going to use splints, and for open fractures, surgery is required for screws and rods. When a patient has pins, rods, or screws for their fractures, you want to teach pin care to make sure that they are keeping everything clean and not developing further infections. So traction. What is traction? It is the use of weights to reduce a fracture and relieve muscle spasms. So there's two types. The first one is skeletal traction. Ignore what I just said about pins for fractures. Pins are not for fractures. Pins are for traction. But screws and rods are for closed fractures. So, my bad. Skeletal traction is the use of pins and rods and weights to realign. And skin traction is, an example of skeletal traction would be like a halo device for cervical traction. So think of Regina George at the end of Mean Girls. And you have skin traction. So these are going to be a harness and a boot to secure an extremity, usually with 5 to 10 pounds of weights. And the purpose of skin traction is going to help relieve muscle spasms. An example of skin traction is Buck's traction, used for a hip and femur. And usually it's only used for less than 24 hours or while a patient is waiting for surgery, just to make sure they are not moving the affected extremity. Complications of traction include neurovascular compromise, which would mean a loss of blood flow and oxygenation to the tissues, joint dislocation, compartment syndrome caused by increased edema and hemorrhage within the fascicle space. And the 6 P's of compartment syndrome are going to include pain at rest, pressure, paresthesia, pallor, paralysis, and pulselessness. And that pallor, paralysis, and pulselessness are going to be some of the late findings of compartment syndrome. The ASAP treatment for compartment syndrome is relieving pressure. And what that would mean is a fasciotomy to cut through the fascicle and release pressure on the extremity. A VET is a complication where blood clots are developing in a large blood vessel, impeding circulations. A VET can lead to a pulmonary embolus, which would cause respiratory failure. You can also experience fat emboli syndrome. It is rare, but it's when fatty bone marrow moves into the long bones and impedes circulation. You also have rhabdomyolysis, which is compression and tissue ischemia seen in crush injuries. You can have hypovolemia, infection, and malunion or non-union. Nursing interventions for traction are going to include pulmonary hygiene, so the use of an incentive spirometer, pain management, antibiotics, anticoagulants to avoid an embolus, wound care, so you want to promote asepsis, elevate the extremity to reduce edema, ice, range of motion therapy to prevent atrophy and VETs. You want to reposition the patient to prevent skin breakdown, educate the patient on hydration and nutrition, and also positive encouragement. And these are just examples of some tractions. So this blue boot on the right, that's an example of Buck's traction. And this is a halo device for skeletal traction, which is used for long term. So next we have amputations. So the severing or the removal of a body part. So there's 2 types of amputations. The first one is going to be an elective amputation. So this is a result from ischemia and cell death. So what happens with these elective amputations is perfusion is hindered and oxygen cannot reach the extremity. Cell death occurs from lack of oxygen and necrotic tissue builds up. An open wound is created and bacteria enters. Once bacteria enter circulation, the systematic effects take place, and the patient will experience gangrene or sepsis. Major complications are going to include infections, which is osteomyelitis seen in older adults. A radiography determines the extent of the bone damage and infection, and veno and arteriograms are going to assess the peripheral circulation of the extremity. And for these elective amputations, oh no, yes, okay. Traumatic amputations, this is when an accident, obviously something traumatic happens, unexpected, and there's no reattachment of this limb. So your first goal is going to be controlling the bleeding ASAP. You can place a tourniquet on the applied extremity for up to 6 hours before necrosis starts to set in. CBC and coagulation panels are used to determine the need for a transfusion. Serum lactate levels are going to determine the degree of hypoxemia. And a major complication of traumatic amputations include hemorrhage, hypoperfusion, shock, and death. One thing to note with amputations is phantom limb pain. So this is numbness, tingling, or a sharp burning sensation in the part of the body where there is no extremity anymore. There's no known cause, but gabapentin is used to help decrease the pain, and mirror therapy has been proven to be effective. When it comes to wrapping the extremity, you want to use a figure 8 pattern starting distal to proximal. If there's blood on the ACE bandage, do not take it off. What you want to do is draw a circle around the blood, and you can tie the bandage tighter. Wait 15 minutes, and then after 15 minutes, if the blood is impeding outside of the circle that was drawn, call the doctor, because there is something not going on and you don't want the patient to end up with one of those complications. You're able to elevate the extremity for the first 24 hours to reduce initial swelling, but do not elevate the extremity after. This will impede circulation and cause further damage. You want to educate the patient about lying prone during the day, like 2 or 3 times for 30-minute segments. And you can apply lotion to the stump to avoid skin breakdown and change the dressings daily. So, cast implications and teachings. When applying a cast, use the palm of the hand only. Fingertips can cause pressure points, which will cause skin breakdown. You want to educate the patient on taking showers, and when they do take these showers, to double bag their cast and wrap it with packing tape, not duct tape. Again, duct tape can cause breakdown. If they're having any irritations with the cast, they can take a blow dryer on a cold setting and blow into the cast, or they can strike the cast with a butter knife, and the vibrations will help alleviate the irritation, but they are not to stick anything at all into the cast. Also, educate your patient on if they're having any numbness or tingling in the hand or the foot, if that's where their cast is, on the forearm or the calf. If they're having any numbness or tingling, the cast may be on too tight, and they should notify the provider. So now we are on to chapter 20. So the first one we're going to talk about is osteoarthritis, which is a chronic condition that causes breakdown of cartilage and bone in the joints. So with osteoarthritis, you're going to have pain with movement, and you're going to have Bouchard's and nodes seen. So Bouchard's nodes are close to the body, B and B, that's how I remember it, and there are nodes seen in the proximal interproximal phalanges. All right, I forgot the name of the other one. It starts with an H, but those are seen in the distal. So I think Bouchard's close to the body, and H is higher up on the hand. And with osteoarthritis, it's going to affect the weight-bearing joints, and it's going to be on one-sided, all right? So rest is going to help reduce the pain. And what's happening here is the synovial membranes are becoming thick to compensate for a reduction of fluid, which is also causing reduction of movement. Manifestations, again, are going to include swelling of the bony prominences, crepitus, and the hands will be tender to touch. Treatments include lifestyle changes, non-weight-bearing exercise activities, because again, those are the joints being affected. You do not want to stress them more than they already are. So think about swimming, or like those like stationary bikes. Tylenol and corticoid steroids are going to help with the inflammation. Complications include chronic pain and decreased function. Surgical interventions for severe osteoarthritis, you can do an arthroscopy to help increase movement. And then again, with osteoarthritis, you want to remember more movement throughout the day is going to equal more pain. So osteoarthritis is alleviated with rest. And morning stiffness usually lasts less than 30 minutes. And then the picture all the way on the left, that's going to be a picture of the Bouchard's nodes. And the diagnostic to distinguish OA from RA can be an X-ray to determine if it is bilateral or unilateral. Might not show OA until it is very advanced. So now we're going to get into rheumatoid arthritis. So rheumatoid arthritis is an autoimmune disorder causing inflammation in small joints. And some of the hallmark signs of rheumatoid arthritis are swan neck and ulnar deviation. So this top picture, this is going to be ulnar deviation. So what that is the fingers start to drift towards the ulna. So the ulna is on the pinky side, and you can see how those fingers are drifting to the ulna. And then swan neck deformity is what's seen on the bottom there, which is when the fingers kind of start to bend, almost like hooks, and that's known as swan neck. Another thing that is seen with rheumatoid arthritis is something called, I forgot, it's boutonniere. So I just remember a swan wears a boutonniere. That's what I think about it when he goes to the prom. That's what I think Level Up RN taught me, and that's what I've been using to memorize it, because rheumatoid arthritis is the pain is alleviated with movement. So the swan wears a boutonniere to go to the prom and dance his pain away. And rheumatoid arthritis is going to be bilateral pain. So it's going to be symmetrical on both sides. And the most common demographic affected is going to be African women. Hot showers can help loosen up muscles to reduce the stiffness. And you want to check the CRP and ESR for diagnostics to determine inflammation. You check the CBC because rheumatoid arthritis causes cytopenia. Cigarettes, bacteria, and viruses are predisposing factors with those with a genetic link. You're going to have mobile and non-tender nodules over those bony prominences. You're going to see scleritis and pleuritis. And rheumatoid arthritis, again, it's an autoimmune disorder, so it's affecting the whole body. You will have stiffness in the morning, but it will get better throughout the day. And you do want to monitor the renal and liver functions of rheumatoid arthritis, because the medications used for rheumatoid arthritis are renal and hepatic toxic. And you have systematic lupus, which is an autoimmune disorder which is attacking healthy tissue and organs. A key thing with lupus is you're going to want to note for a butterfly rash and photosensitivity. So females are more affected, and this is going to spike during childbearing ages. And African females are the most affected. I think I also said that for rheumatoid arthritis, but I don't think that's true. So, triggering factors of SLE include pregnancy, sunlight, illness, major surgery, silica dust, med allergies are all going to increase stress. There is no specific diagnosis for SLE. You want to check the ANA values for lupus. And you also want to check the CBC for that leukopenia. You want to check the protein and creatine levels, and as well as inflammation markers. So that's going to be that CRP and the ESR. So teachings and treatments for lupus, you want to avoid sun, have rest regular, and no smoking. For the medication for lupus, they're going to be anti-malarial meds. So you want to make sure to check their eyes because those are retinal toxic. Ibuprofen, immunosuppressants, and corticosteroids are used for the treatment of lupus. And nursing management is really just helping out with flares. So you want to check vital signs. You want to look at the blood and creatine levels. Make sure the patient is not overstressing themselves and wearing sunscreen. And you also want to avoid birth control in patients with lupus.